Now, one of the reasons why the focus framework is here to guide you, to remind you of what is most important, okay? What is most important. So, if you think about the sides of a triangle, right? You have the sides of the triangle, and then you have your foundational knowledge. Your foundational knowledge, what is your foundational knowledge? It's your general knowledge. It's what I call general knowledge, right? This is going to be your anatomy. This is going to be the names, quote unquote, the names of things, names of tests, names of people, names of structures, names of surgeries, you know, all the things that sometimes we think about as the order in which the names of the nerves, the order of the nerves, right? This is all fundamental foundational knowledge. The nature of fractures, how it heals, the nature of tendons, how that heals. This is all general knowledge. And sometimes, you know, all the names and the little nuances. Oh, the directional pull of things, the type of joints. This is all foundational knowledge, right? And then from there you have, because you know all of that, you can extract the information and do an evaluation. What is the point of an evaluation? The point of the evaluation is to locate the problem, right? What's the problem? Certain things that we need to take into account when we're doing an evaluation is age, past medical history, past medical history. Sometimes that's really relevant, right? We need to know work, function, right? All those types of ADLs, activities, and then evaluations, testing, right? Testing is essentially ruling in and ruling out. You have to know how to test for something. Ruling in and ruling out. Is it a fracture? Is it a ligament? Is it an intrinsic or extrinsic problem? That type of thing. Ruling in and ruling out. And this is in general for everything. It's not just for the fingers, it's for the wrist, it's for the elbow, it's for the shoulder, it's for nerves. And then in the evaluation, you have to know things like we normally look at: range of motion, grip, sensation, those type of things. The only way we know what the problem is essentially through our evaluation, right? And then from evaluation, we could look at prognosis. So when you think of prognosis, you can think of, when am I allowed to do something? When am I not allowed to do something? At what time? What's my timeline, right? Based on the evaluation, what are the problems so that I can work on creating that plan of care? So I have someone with edema and decreased range of motion. What's my prognosis? You know, what's my prognosis on how long it's going to take me to get the edema down, to close that wound, to anticipate problems, right? My plan of care. If I don't get that MP down into flexion, they're going to get stuck into extension. That's kind of like prognosis, right? Knowing that timeline. At week 4, at week 6, at week 8, that's prognosis. And then treatment, right? Treatment. So how do we, under treatment, how do we, as the certified hand therapist, solve this problem? How do we help our patients? Do we do it with splinting? If we splint somebody, which splint is it? How long do they wear it? When do they wear it? When are they allowed to wear it? Range of motion. What are their exercises? What are you ranging? Are you doing active? Are you doing passive? Which one comes first? Right? What are the activities? What are the phases of the treatment? How do you progress someone? How do you know when they have stopped progressing? So I'm talking about it in a very linear way, but many times as the certified hand therapist, as you're treating, you're evaluating. And then as you're evaluating, you found a problem. And then you have to change your plan of care, right? If you're working with someone and they're not making any progress, then what do you need to do? You got to change your plan of care. You got to say, hey, at some point they need another surgery. Hey, at some point I found this other new problem, right? All right, perfect. All right, my board flips. Now, I'm a big fan of drawing things out. Draw on your hands. You have cheat sheets that you have in the exam, right? And one thing I was telling someone the other night was, when you draw on your hands, try to use the same colors, right? Try to use the same colors. Like if you have dry erase markers, Crayola markers can be really nice. I was using this felt tip that my assistant had, and it was hard to scrub. I was like, I'm gonna be careful not to use her markers again, because they were very nice to draw with, but didn't come off as easily. But when you draw it out on your hand, get really specific. Get specific with the words that you're using, right? Get really specific with the, when you're describing something, to use the words. Don't just be like, well, it looks like this, right? You want to say, well, wrist is in slight flexion, MP's in, 70, 80 degrees of flexion, IPs are extended at 0. Things like that. Getting really specific with it. And one of the reasons why you want to do that is because the exam is all specific. And it's all one-dimensional because you read it, right? When you start speaking to yourself with like that type of specificity and just being able to take something that seems so one-dimensional reading, taking it to a 3-dimensional where you're moving, it's going to really help you to be able to problem solve on the exam. All right, so let's go through some anatomy. I did receive some questions, so I'm gonna answer those, but I'm also gonna put some of that into the lecture, okay? And like I said, if you have questions, just let me know. All right, so I always draw out and one of the reasons why I draw out very boxy is because the drawing doesn't really matter. It's the understanding of it that's going to help you, right? So this is your metacarpal, this is P1, P2, and then P3, right? So let's go through some of this anatomy and understand what all of this means. So there's a couple of different things that you want to pay attention to in these chapters that you're reading. Try not to get too bogged down with very, very detailed, right? So how do you simplify some of this stuff and say what's the most important aspects that really help? All right, so if we're looking at the distal transverse arch and then the proximal transverse arch, then one of the reasons why, obviously this is the proximal, and then this is the distal, and then the longitudinal. So the longitudinal goes from tip to palm and includes the metacarpals and fingers, right? It's your arches. Your longitudinal arch. So this is proximal, and then this is distal. So from tip to palm, right? And then your distal is the metacarpal heads have like some moving space across the MPs and fingers, and then your proximal transverse arch across the MP and wrist, where the metacarpal bases are they're positioned real tight. So we look at it from, this is the volar, and if you remember, as you read, you almost have to do this like translation. Everything they're talking about is in anatomical position. So this is volar, this is dorsal. So if you take a look at your MP, like the heads right here are supposed to be loose, and then the base here is much tighter across that wrist. Right. And Gina had a question about like how detailed, like what are the importance of the bursas? And if you think about the purpose of a bursa, the purpose of a bursa is to give you cushion, right? It's to give you cushion. And if you start seeing words like radio and ulnar, it's just positional. It's just to tell you where they're positioned. So we have a radial bursa and an ulnar bursa, and that just gives us extra cushion. So what's the importance of it in the hand? Well, importance of his hand because we don't have a lot of tissue, so it protects the tendons underneath the structures. What's important of the arches? It's to allow us to be able to cup our hands in functional position. It allows us to move in a way that gives us fine motor coordination. So if you were to lose those arches, you would have like a flat hand, right? You would lose function. So always think about that in that sense. Now, again, when you start studying about the metacarpals, don't get boggled down with knowing way too much. If you look at your hand, it's gonna give you some clues. So the metacarpal heads here, again, they're much looser, and it's because it's attached to your fingers and it allows a lot of motion. The metacarpals down at the base, attached, they have articular cartilage and really attached to, or has a articular surface to the carpal bones, right? They articulate with the carpal bones, and those joints down there at the base of the wrist, those ligaments are really short and tight and give a lot of stability. And that's what allows us to do a lot of weight bearing, right? So if you think about the second metacarpal and the third metacarpal, they're your largest metacarpal. And they're unique because it has a sideloid, it has a bump, so it could take on greater weight bearing pressures. All right, it's also an attachment for the ECRB, the ECRB.